Teste Cardiopulmonar de Exercício. Hoje você vai aprender sobre esse teste com 2 especialistas internacionais da área. Fique ligado. Olá, seja bem-vindo a mais uma temporada do 4HealthLab Cast, podcast do 4HealthLab. Nessa nossa segunda temporada, nós estamos estreando no mais alto nível. Nós estamos recebendo 2 convidados internacionais e, por isso, nosso podcast vai ser em inglês. Mas antes eu vou te falar do tema do podcast. O podcast vai ser sobre teste cardiopulmonar de exercício. E, para isso, então eu vou mudar agora para o inglês para apresentar os nossos convidados. So, first of all, I would like to thank our guests, our special guests from Italy and for Belgium, to talk about the cardiopulmonary exercise tests as two reference for this type of tests. And we will talk with a conversation about the limits of this test, the barriers, and the technical aspects, and also the all consideration for medical studies, for studies from physiotherapists. So thank you for coming here. You just arrived, so you are also in a jet lag, but I would like to thank Professor Gael Deboeck from Università Libre de Bruxelles. Not, I think it's correct or not.
Perfect.
Okay. And Professor Marco Vicenzi from Università degli Studi di Milano, from Italy. So, very nice to have you here, have you both together. So, to start our podcast, maybe you can introduce ourselves and talking about why do you choose your career, for example, physiotherapist and medical doctor, how you choose start to work with the CPET, the cardiopulmonary exercise test, and yes, with yours.
Please, Gael.
Who begins?
Gael, start. Please.
Okay, so my name is Gael Deboeck, and I studied physiotherapy. So I did my end year work in cardio physiology and exercise testing, and I studied the adaptation during a 6-minute walking test, and that was quite a big interest for me. And then I decided to do a PhD on that topics, and so my whole PhD was analyzing the cardiorespiratory adaptation during the 6-minute walk test. And we had to compare this adaptation to a standardized test, that is the cardiopulmonary exercise testing, that gives you the VO2 max, aneroic threshold, and so on, ventilatory threshold. We talk about that maybe later.
Yeah.
And so, yeah, that was my great interest after my studies, and so therefore I did a PhD. And during the time I did my PhD, I was working as a physiotherapist in cardiorespiratory readaptation. And because of my interest and my specialization in exercise testing, I did cardiopulmonary exercise testing for patients doing rehabilitation, and also cardiorespiratory rehabilitation. I did that for nearly 15 years, and then I'd had a position at university. So now I'm professor at a university, and so I give lessons, and I do a bit of research as well.
Yeah, very nice. And you, Marco, why did you decide to choose the medicine and exercise test?
It's a long story, so
okay, no problem.
I will not make bore you. So, so my career in the ergospirometric field starts in I think 20 years ago, more or less, with Marco Guazzi. I don't know if you know, or if other one knows. That is an Italian professor in cardiology, famous for his interest and competence in this field. So I had a chance to work with him, and I was a student. So my first view of cardiopulmonary exercise testing was I was student. So I started with collecting data, collecting right test, and I could understand not anything because it was
just for collecting the data and
just for collecting data.
Yeah.
So, but it's still something good because if you start to collect data in the right way, is half of work. Okay, and my main interest during my growing up career was the chronic disease, and still the chronic disease. So I'm cardiologist, and my focus is heart failure, global heart failure, so right and left heart failure, with hemodynamic imbalance, so pulmonary hypertension, left ventricular dysfunction, and also right ventricular dysfunction. So I think that CPET is a mandatory tool and a very fundamental tool we need to study this kind of field in cardiology, and to assess in a very comprehensive mode way the chronic patient. So then I move from Milano. I move in Belgium, where I met Gael, and in 2012, so 14 years ago, and our friendship is still live. And then I met you, Gabriel, in Milano, and so this is my career in a short way, so an abstract of my career. Stop, fine?
Yeah, it's good. So to start the topic here, where in our audience we have expert or non-expert in this area, so we can start with the zero. And for you, what is the CPET, and what's the difference between CPET and the exercise testing without ergospirometric measurements, without ventilation, without gas exchanging? For example, the test conducted by a doctor with only EKG for medical reasons, and what's the CPET, and what's the difference between CPET and the other exercise testings? You can start.
I do.
But I start from difference.
You start from where you were.
I start from the last question, so the last part of the question.
Okay.
So the big difference between cardiopulmonary exercise testing and the normal standard exercise tests is in the type of tests. So the standard exercise test, so I mean what you said, so ECG, EKG monitoring, blood pressure monitoring is a provocative test.
Okay.
Usually is a provocative test. So I put the patient on bike or on a treadmill. I push the patient to effort, and I try to provoke something. So it means that usually I provoked an ischemia. So the goal of the standard exercise test is to provoke a myocardial ischemia, just to test the coronary circulation or the what we call coronary reserve.
Okay.
So actually, this is a fast test, so very easy, very accessible, available everywhere. And during this test, we can monitor also heart rate. So how heart rate increases during test, how heart rate reduces after the test. We can check the blood pressure. So maybe we can use this test for to assess the blood pressure response. So maybe in case of latent arterial blood pressure hypertension, or even in condition of arrhythmogenic substrates. So we can check if ventricular arrhythmias stopped during effort or remained during effort. So it's a big difference in clinical activity, in clinical diagnosis. So this is the standard exercise. The cardiopulmonary exercise testing is not provocative test, is an adaptive test. So we aim to assess and to check how the cardiopulmonary system adapts during effort. This approach does not limit the assessment of eventual myocardial ischemia. So it's not a substitution of standard exercise testing. Is another type of test that can do the same response, the same answer, clinical answer of a standard test, but can give us more information about cardiorespiratory response. So maybe Gael can discuss more and deeper the technical issues and the technical characteristics of like testing.
What kind of this cardiorespiratory response you're looking for with this test?
So
usually we use cardiopulmonary exercise testing to test eventual limitation of exercise, eventual symptoms that are exhibited during exercise, so dyspnea, fatigue, or something, or muscle pain, muscle fatigue, and we use cardiopulmonary exercise testing for that.
Okay.
Yeah. So, as Marco said, that's the beauty of the CPET is that you have measure like at every steps of the oxygen flow from the atmosphere to the muscle, and so you can measure every system. So you have the lung system, the cardiovascular system, and the muscular system involved in producing energy. And with the CPET, you can measure ventilation with the mask. You can measure how heart rate will adapt, and also how the oxygen is used by the muscle to produce energy. And you also measure the production of energy because you have an ergometer that produces energy. So you have all measurement at every steps of the oxygen flow to the muscle. And you can, by recombining all those measurements, you can say where is the limitation for the oxygen flow to the muscle. So if it's a respiratory limitation or cardiovascular limitation, or even detraining or a muscular limitation, you can see it with the cardiopulmonary exercise testing.
Yeah, it's nice because you also can associate it with the symptoms of the patients, right? With dyspnea, for example, with peripheral pain or limitation. Do you find some patient that has not a dyspnea, for example, but has peripheral limitation that is a limitation for the conclusion of the tests? And how could you use this test with considering this limitation? For example, an untrained patient that arrived for you with this limitation in the the test was not completed, and how do you proceed in that case?
Actually, the main symptoms at exercise is dyspnea. Usually, I guess the patient comes to say, okay, I'm dyspneic, I have problem with exercise. You may, and then you have to fit the symptoms with the cardiopulmonary exercise testing. With the cardiopulmonary exercise test, some symptoms may be cramps in the legs or something like that, of course. But here the idea is to fit the symptoms with the graphics, with the measurement.
But also with the protocol, or no? The protocol of the tests is individualized for each patient, or
so the protocol should last between 8 to 12 minutes. So we have, that's not really easy, but you have to guess actually what is what will be the exercise performance of your subject. So by questioning him, you can say he will do 80, 100, 150 watts, and so you have to adapt the incremental protocol to have a long enough test, not too long, not too short, because that may have impact on how all the process adapts during exercise. If it's too short, sometimes it's not easy to find and to find where the limitation is. It's too long, maybe the patient will have fatigue, and but before the true maximal exercise capacity.
Actually, I was thinking that another sensible or difference between standard exercise test and cardiopulmonary exercise testing is the protocol, indeed. So due to the fact that standard exercise test is a provocative, we normally use step by 25 watts per step. During cardiopulmonary exercise test, we use ramp usually. So it means that you divide in a minute an increase of 5, 6, 8, 10, 12 watt per minute. So it means that every single step is distributed along a minute. So this is the typical protocol to define the adaptive protocol, so the adaptive system. And this is interesting because we can simulate a daily effort that patients exert at home or in a daily life. So if the patient go to the supermarket and refers dyspnea, we can test in a personalized charge, in a personalized protocol. We can test and simulate the same efforts. So it depends on the level that the patient achieves. So this is specific for CPET and not for a standardized exercise test. Yeah,
it's very interesting because it's a perfect link for the other question about the 6-minute walking test. This simulate the daily activity of the patient, and you have, Gael, some interesting research on that with CPET during a 6-minute exercise test. We have both together a paper with that, and why this is so interesting. Include the CPET assessment during the 6 minutes exercise test.
So the protocol is quite different if you do a 6-minute walk test, because it's a constant load protocol for 6 minutes, and 6 minutes is quite a long time to let all the system adapt to exercise. And that is different from CPET, where the protocol is increasing the workload, and so it might be interesting to measure cardiorespiratory adaptation during the 6-minute walk test to see what are the level of ventilation, of oxygen consumption, and heart rate, of course, during the 6-minute walk test. We showed that it was the performance to 6-minute walk test was related to, by example, ventilatory equivalent, so hyperventilation. People hyperventilating more do less distance, by example, and that is an add-on to the 6-minute walk test, because 6-minute walk test is quite basic. You only rely on the distance performed in 6 minutes. What is actually still quite a good index of exercise capacity that is related to prognosis, to exercise capacity, and to VO2 max as well. So actually, there would be an interest to mix cardiorespiratory evaluation during 6-minute walk test. But the annoying thing is that it would complicate the protocol of the 6-minute walk test, of course, because 6-minute walk test is quite easy. You can do it in let's say 15 minutes, but if you want to have a cardiorespiratory measurement, that it will take longer.
But in your opinion, is not a substitution for the traditional CPET, for example, for diagnosis?
No, I don't think you can, because with the CPET you have all the adaptation during an incremental protocol. CPET is a 6-minute walk test is a constant load test. So it's quite different. You will have different information, and actually, that's I think that's the beauty of the two different tests. CPET will stay, I think, the gold standard for evaluating the exercise capacity of a subject,
maybe the 6
everybody, because 6-minute walking test is not for health people, it's just for patients. You agree with this?
Definitely, of course. The problem with healthy subjects is that they won't be limited by the cardiorespiratory system when they do a 6-minute walk test. If they do a 6-minute walk test, they will be limited because they cannot walk as fast as they would, as they would, because they are limited by their locomotion, and patient will be limited because of respiratory or cardiovascular adaptation.
That's good. And talking about the sports field, why the CPET is interesting, for example, for sports and for health people, for example.
So
because I've not experienced.
You have experience, with the sport field.
I work now in a sports center.
Gael is the best expert.
But for athletes, it's interesting because you can measure the VO2 max. Everybody knows about VO2 max. Is the maximal oxygen use you can do during exercise. So it's the best performance your cardiorespiratory system may give. And you also have the evaluation of the ventilatory threshold or the anaerobic threshold. It's better, I think, to speak about ventilatory threshold. This is quite different. There is a lot of literature about the anaerobic threshold and the ventilatory threshold, but it's not the point today, I think. But so you can have different steps during exercise that is really related to the fitness of the subject, and so you can say if a subject is really fit or less fit, and you can measure the evolution of the fitness with the training, like with the patient, actually. So that's quite interesting to analyze that and to collaborate with trainer because
for exercise prescription, for example.
For exercise prescription, for training and so on.
Optimized protocol training. I think we, if I'm not wrong, we had a discussion about the recovery phase.
Yeah.
So I think in health people, what CPET can do is analyze the recovery phase also.
Yeah.
So it means that we discussed about the capacity of recovery. Do you remember?
Yeah, but there is not much literature on recovery, and usually
on health people.
On healthy
because
people, but
because
even
in patients
in yes, but there is a bit of literature, I think, and there is actually that's you're true, there is, but with healthy people we had that discussion, of course, because we did some measurement, but it was on heart rate recovery. Things are not so clear in the literature, but that's the recovery phase of the cardiopulmonary exercise test.
Or I have a question. It's not.
You can make questions.
Do you know the utility to perform exercise cardiopulmonary CPET, simulating an interval training? So.
Yeah.
We
did that. I didn't, but my colleague did that a few years ago, and that is also interesting to see how the respiratory exchange ratio will adapt during the training, and that is quite that is quite interesting, because you see that the respiratory exchange ratio will go higher than 1 during the high phase of interval training. And then you recover with the air respiratory exchange ratio lower than 1, meaning that you will really pass from one energetic pathway to another during interval training, which
and
is
this
the goal.
The characteristic of the most of sports, right?
Of course.
It's interesting because it's fit the nature of the sports.
Yeah, definitely.
And you mentioned the difference between the anaerobic threshold and ventilatory threshold. Mm-hmm. Maybe you can talk about that. It's very interesting.
Oh yeah, that's.
We have 1 hour to.
Just comment the difference, because.
So anaerobic threshold is like an old term. That was introduced by Carman Wasserman, who is the pope of the cardiopulmonary exercise testing, and many of the literature we have, and many of the tool we use now come from his work and work of his team, of course, it is supposed to translate the fact that when you do an incremental test, you have that respiratory exchange ratio passing from less than 1 to higher than 1 to more than 1, and when you analyze the production of energy with glucose, oxygen, and the ATP production and the CO2 production you have, it's not possible to have a respiratory exchange ratio higher than 1 if you don't use glucose anaerobically. And so he said that is a threshold where the production of energy becomes anaerobic, which is not really a threshold. It's not really true like that. You use different energetic pathway proportionally differently during all the exercise. Okay. But what we can see during a CPET is that you have that area coming from less than 1 to higher than 1. And at that point, you also have ventilatory adaptation, because ventilation is adapted to the production of CO2, and partial pressure of CO2 in the blood will stimulate the chemoreceptor and provoke hyperventilation. And you can really see a clear point during the CPET where the ventilation will adapt differently and will change of slope, and that is the ventilatory threshold, because that is more related to what we see, and anaerobic is maybe not the perfect determination of that point, but it is a point, and that point is really related to the fitness of the subject, and that is the first ventilatory threshold. Above that point, we see that when you do a constant load testing, people will keep hyperventilating because they are producing more and more lactic acid.
Yeah, good. And talking about the ventilation, Marco, why the ventilatory efficiency so important for the patient? It's questions for you.
Hour, because Gael took 1 hour.
You're an expert in ventilatory efficiency, so it's a question for you.
I'm not expert. I'm some experience, but
Yeah, you are.
no, I am. No. This is the link to talk about the clinical importance of CPET. So I think that CPET is a very unique and special tool to assess non-invasively the cardiopulmonary hemodynamics and over than cardiopulmonary adaptation, cardiorespiratory adaptation. So what you told me is that ventilatory efficiency is specific parameters that links the minute ventilation, so the amount of air we exchange in a minute, with carbon dioxide production, so the VCO2, what we call VCO2. So it's the ratio VA, ventilation, on VCO2, and is the parameter that reflects the efficiency of the ventilatory system. So ventilatory system is not only respiratory system. Mechanical. Ventilatory system is the global hemodynamic, circulatory, and respiratory system of the cardiopulmonary system. Yeah. So we have to think and to see the cardiopulmonary system as a unique system working all together. So the lungs and the heart are working together to maintain a correct ventilation, so a correct value of VA VCO2. Yeah. So this is the definition, the physiological definition of VA VCO2. So the efficiency is ventilatory efficiency. So in clinical, we use this parameter to stratify the cardiopulmonary disease, the cardiopulmonary unbalance. So it means that the normal value of VA VCO2 is around 30. If this value rises up, greater is the imbalance of right side overload of the heart. So this is a degree, this is a nuance of values that can define a priori, can define where the disease is. So is in the left side of the heart, is in the middle of the pulmonary circulation, is in the part of the arterial pulmonary circulation, is already established in the right heart overload. So is the right heart decompensation, failure. So it's very useful to stratify the localization of the problem, of the issues. And if we match the value of VA VCO2 with the other CPET parameters like VO2, like oxygen pulse, like anaerobic threshold, we can distinguish the limitation of the exercise. So we can define if the exercise is limited by cardiac origin, cardiac cause, or respiratory. So it means the lung disease cause. So
here you should refer the subject to your last paper.
Yeah.
Yes, because it's I make easy.
Yeah.
Just for discuss, I make easy.
Yeah.
But is the
you validate this.
Complicated.
Yeah. Because it's really awesome because we can evaluate all these things with a non-invasive test, but you also correlate these parameters with invasive measurements. For example, hemodynamic. For that we can say that is good stratifying for the type of the disease of the patient. For example, precapillary and postcapillary.
We can say that VAVCO2 is a sort of resume of right overload, where right overload is determined by a series of determinants. So hemodynamic, parenchymal, compliance during effort. So it's very complex parameter, but it's very useful in clinical activity because it allows to define or set clinical probability to have different type of hemodynamic imbalance among the cardiopulmonary disease.
But do you use this for decide, for example, a drug or medication for the patient with the CPET or not?
Not alone. So usually to decide the optimal treatment, we need different type of tests.
CPET is part of
CPET is a part of
the screener.
We need echo, principally, and sometimes we need also hemodynamic phenotyping. So it means right heart catheterization, and not only at rest but also during effort. So the field is very complicated. So it's not so easy going deeper in the pulmonary circulation, but it's very fascinating and a fascinating field because it's like every patient is something new.
Yeah,
so it's different.
Yeah,
and every patient is unique.
Yeah.
So this is a very stimulates your brain to think on the patient, to think which kind of treatment is best for him, and personalize the treatment.
No, it's very nice because it's matched the idea of precise medicine, personalized medicine. Yeah, it's good. And here you talked about the VO2 max, and the VO2 max is the most used marker of aerobic capacity, but we have other markers of capacity. Is the VO2 max not the only one? And maybe in the literature or in the application of the CPET, the person, the trainer or the physiotherapist may look only for the VO2 max as the unique parameter. So how do you feel? How do you think is the other markers should be used for assess the cardiorespiratory exercise response?
Yeah, I think VO2 max is a really interesting parameter. Of course, it has been shown from the beginning of the story of the cardiopulmonary exercise testing. But of course, like you said, there is many other indexes that will explain the cardiorespiratory adaptation during this incremental protocol. Of course, we have already spoken about that ventilatory threshold, which is the other quite famous anaerobic threshold index of the during the testing, that is really related to the fitness of the subject, and that those are two both level of the exercise that are mainly used to prescribe training. You have another point, that is the respiratory compensation point, that is the second ventilatory threshold, and that is really important as well. It's the point behind which you begin to you are not able to buffer the acid lactic anymore, and then you hyperventilate very much and so on. So behind that point, the exercise will last 1-2 minutes, and then it's over because you cannot do more. So that's basically the three real thresholds during the testing that may give you information on how you have to train the subject. You have another point, but it is not directly measured during the cardiopulmonary exercise testing, is the critical power, which is somewhere between ventilatory threshold, the first one, and the second, so the RCP, respiratory compensation point, and which is the power that is critical because it is said that it is the maximal power you can sustain for a very long time without being exhausted at the cardiorespiratory point of view, and of course muscular point of view as well. So it is the power that is critical, and if you go above that power, then you will faint, and you can stay a little bit lower and maintain your effort for a very long time, and that is to determine the aerobic fitness of the subject. And then behind those 3-4 index, you also have all the different index that are more diagnostic index. For example, if you look at oxygen pulse, the evolution of the oxygen pulse, if it breaks during the test, that is really problematic because you have to look after maybe an ischemic process going on, and it has been shown that break in the evolution of the oxygen pulse appears before the ST depression that you will see when you do classical exercise testing. It has been related to how you say that, metabolic disease syndrome, metabolic syndrome.
Mitochondrial disease.
Mitochondrial? No, I mean with clinical metabolic syndrome. Let's say diabetes, hypertension, obesity, and so on. So it's like a first index saying to the subject, be careful, you are doing bad, and you have oxygen pulse breaking or going down. That's even worse. So that is one index that is quite interesting. And also on the respiratory point of view, it has been more developed these last 10 years, maybe 10, 15, I don't know. Years, is the evolution of the inspiratory capacity that will explain how the respiratory system adapt, and it's known with COPD patient that they might do dynamic hyperinflation, and you can measure that with a CPET, but you have to add inspiratory capacity measurement during the incremental process of the test. So those are like index. There is more. Ventilatory efficiency is another, and some more, and so on. But
it's nice. And let's talk about some weak points of the CPET, like the costs. I don't know if you know the cost of the, and I think the good point is a trained staff, because the CPET needs a trained staff, not only for collect the data, but for analyze the data, for interpret the data. So how do you see these points, the costs and the training for the CPET assessment?
Yeah, you're right. The weak point of CPET is the cost, even if it's not so much expensive. So it depends on what you are thinking. I mean, in the general economic balance of health system, I think that in Europe, CPET system costs around 20,000-30,000 euros.
Here
really, in a global system, it's very few euros, so it's not so expensive. But you're right on the learning curve. So operator, technicians have to be trained, and the curve is not so short. If I look my career, I think that I started to look the CPET in a correct way. I started to put everything together and do the best interpretation of the test after my Brussels experience. So it means 7 years after I began to look CPET. So and I did CPET every day during the 7 years before I arrived in Belgium. So I was not a beginner. I was already experienced. So it means that the learning curve is around some years.
Here, I think that is really important. It's like every process of expertise. If you want to be an expert in an area, you have to do it, of course, repeat it really often. But you also have to confront yourself to your peers, to go to formation, education, and so on. And that's what makes you grow in the ability to perform. But as he said, it's really.
But sorry, Gael.
No.
For example, I usually train my young colleagues, students in Milano, and they are able to collect a correct test in 2-3 months. So after. There is a period to train the interpretation, but just to collect the test, just to do the test in the right way, it takes 2-3 months every week. So one time a week. So
is the I mean,
just follow instructions.
But this is so important, because if you don't have correct data, we don't have a test, so it's impossible to analyze wrong data. So you need to start from the data collection, right?
And that is really, really important. We said earlier that you have to have a test that will last between 8 and 12 minutes, but that's really a milestone of the test, because as you just said, if you don't have a right test, just cannot do anything with it. And
no matter the analysis.
I think you still need to have a bit more experience than 2-3 months, because maybe for a security point of view, that you have to look at the patient and to be sure he's safe.
Okay.
But you have some pitfalls that you have to learn, like if you are a problem with the oxygen analyze or ventilation, if you are leaks, technical issues, you need a bit of experience to see it happen and to maybe stop the tests and redo a calibration or something like that, and to redo it a little bit later. But if you don't see during the test, you stop the test. Okay, your VO2 max is about a liter, and you do 250 watts. That's not possible. So so you have to note that during the test. And as I said, you need to train.
Yeah, I agree. I am always in the corner, so if something happens, I'm there, so I can say my thinking, and I can stop eventually the test. So, but I would be back in the on the what I told you before. So in the economic global economic health system, I think that CPET is an advantageous tool, because it allows to spend less than without CPET, because patients with dyspnea with symptoms usually see a lot of doctor, a lot of medicine, cardiologist, pneumologist, generalist, amount of exam, blood samples, pulmonary functional tests,
imaging,
and then nothing. Your dyspnea is unknown. We cannot explain your dyspnea, so remain unexplained dyspnea. With CPET, you can make easy, really. So it is not needed. See, this all these doctors. It's not needed to have blood sample every 3 months, because just CPET.
Yeah, it's like a little bit of nonsense to analyze patient coming to tell you I'm dyspneic when I do exercise, and all the tests you do is at rest. And you can just put them on a bike, and you measure how the cardiorespiratory system adapts, and then you see, okay, then you have an illustration of what really happens during what they feel. So so that is one big argument, I think, to say that is really important to do CPET.
I think it's a big problem for the patient, because if the patient has the dyspnea only doing exercise, he becomes more sedentary, because we need to avoid the exercise, and so if the game changing also for the patient have a diagnosis with CPET.
That is really a physiotherapist message. Function, give function. If you do exercise, you will improve in your exercise. But for every function of the body, if you use the function, you will improve the function. So
this is important also after an acute event. So maybe myocardial infarction, reacutization of heart failure. So if you do CPET after this event, you make more confiance. You make more confidence in physical activity, and the patient can do that alone at home, safe. So CPET is a tool to take in charge the patients in a 360 degree.
It's very nice.
And physical activity will improve the pathological process of a coronary patient, by example, or so on. It will take care of the cholesterol, of the body weight, glucose, metal. Everything will improve with exercise. So of course.
Do you see in your practice the improvement of the patient during, for example, an exercise rehabilitation before and after a CPET assessment?
Yeah, definitely. We used to measure about between, I'd say, 15 for the lowest and 50 for the highest improvement. Generally, is between 25-30%. You can expect between 25 and 30% of improvement, and you see that improvement on the VO2 max. You see the improvement of the first ventilatory threshold, and all the threshold of the test, of course, of the maximal power performed, and that gives an illustration on how the life is more easy for the patient now. English sentence wasn't perfect, but I hope you understand what I said. So the illustration with the CPET gives the quality of life of the patient, and if the VO2 max is higher, usually quality of life is better, even if there is no direct link between the standardized laboratory testing and the quality of life, but at least it's a part of the illustration.
Yeah, but my experience is complementary to that Gael told. I think that exercise, physical activity, is able to reduce chronic inflammation. No, it's not my thinking. It's
true.
It's demonstrated. So I think, but it's not my thing. I believe, I certainly believe that this is the mechanism. And in chronic patients, irrespective of the cause, so it means high cholesterol, intolerance of glucose, so not diabetes, but quite diabetes, arterial hypertension, cancer, and other any other chronic condition determines rising up in chronic inflammation. So what we call low grade chronic inflammation. So we explored something in systemic sclerosis. Do you remember? We try to check if protein C reactive was correlated to interleukin or not. So, something specific, not for this cast, I think. But this decrease in low-grade inflammation determine a reactivation in endothelial function. That is the main mechanism that regulates the circulatory compliance. So it means that if you act on this main mechanism, primum movens, Latin say primum movens, if you act on these primum movens, you can regulate everything is after in the
pathway.
In the pathways, thank you. So my experience is in the arterial hypertension. So when I start with Marco Guazzi, we test a lot of low grade or borderline arterial hypertension or patient with chronic arterial hypertension on treatment, but with values that were not so optimal. We test patients. We gave them personalized training for 3-6 months. We retest the patients. They improve VO2. They improve their blood pressure, and they improve their endothelial function. So it was a positive response. Just with physical activity, just with personalized training. The problem is the compliance, because it's not a pill you take, is effort, is engagement. So every people wants do sport is engagement. It's not a pill you take at 8:00 and then tomorrow 8:00 another pill. So the pill can help, but physical activity can change.
Yeah. And the people have preference about the exercise, so you need to adapt your routine for the exercise. So of course. And talking about the future of the CPET, I don't know if you have an opinion of the wearable technology to use CPET during outside, and maybe the future analysis. How do you see the future of the CPET?
Wearable devices like watches or something. Yeah, the problem with those devices is that they don't directly measure what happens.
Perfect.
So they have predictive formulas that will give an appreciation of what should be VO2 max, given that your wrist is moving as much during the day. And all those formulas are predicted based on the age, the sex, height of the subject, the weight of the subject, and so on. But there is a lot of error. And so it may give a good representation of what happens if in a population, by example.
Yeah.
For you if you have that watch and you look, my VO2 max is as much, you have to expect some error, and the error may be so that means that your real VO2 max may be really higher, but it may be also really lower.
Yeah.
And it's about, I'm not sure of what I said, but I think it's about 20% of error. So it's quite an amount. So of course it may give, I think in political health point of view, it's really interesting because it helps people to move, and for society it's really important. If you speak about determining the threshold, the VO2 peak, that's really complicated. Many reports on that are saying all the same thing. So that's a problem. After, that's for the wearable device, and you have many devices coming. It's really nice with a ring that will analyze based on the pulse that will give you your cardiac output and so on. And that is really interesting. But there is always error because it's based on assumption and of predictive value, predictive formulas. Besides, I think maybe more clinically you can have, and that Marco can tell us a lot about that, is combining cardiorespiratory measurement with echocardiography, by example, during exercise, and you look at the functioning of the heart and you register during that time the cardiorespiratory variables. You can link the ventilator equivalent with the functioning of the heart directly, and you can measure pressure and so on. Maybe you can.
Well, my thinking is that the future is now. So someone just say that the future is now. But it depends on how we use CPET. So and how many people start to use CPET. So the diffusion of CPET is the future for now. Because we need to diffuse the method, to apply the method, to correctly apply the method. So it means we need training, we need sensibilization, we need people that daily every day do CPET. So both in health people or in clinical activity. So I make no difference. I think the football team in Italy, someone did a Physiolab like AC Milan, but they are not focused on the CPET derived interpretation of the level of training. So
I think we can come back on what you said previously, is that it's an investment because it's not so expensive as an echographer, I think, or a cath lab, of course, but it's still 35,000 euro, at least in Europe. So it's not so easy to buy. Moreover, if you cannot use it properly, you have to be trained and so on. So it's very difficult, and also it's not good. There is no good reimbursement by the health system. It's reimbursed, but only for specific disease. So with no healthy subject, it might cost a lot for the subject. So sometimes it's difficult, but it's a whole system that has to adapt. Because as you said, I think measuring cardiorespiratory fitness with people, even healthy subject, and maybe more healthy subject, will lower the price behind, because the health system will not have to care about the treatment on hypertension, because you will have seen it before, but it's all it's all a different mindset for the health system.
I think that another future perspective of CPET is an integration with we are in the moment of AI, so I think that an integration with AI can help in interpretation, because actually is very time expanding. So after 20 years in this field, I can do a CPET in 40-45 minutes, not less. So it means that usually in hospital we take 1 hour for a patient
to calibrate and prepare the patient,
to dismount the patient, to clean the tools, to prepare the so if I am alone, if I'm not with young colleagues, it can take 45 minutes, not less, and I'm experienced. If I look in the direction of diffusion of the methods, I think we need to make the method faster. So the integration with AI, I mean, I'm working on. I have some idea I'm working on. So put in the software some clinical information of patient, and the AI can match the clinical information with the result of CPET. So it means, okay, the patient is cardiac patient, so I have to interpret this VA-VCO2, this VO2, this oxygen pulse in this way. So it means that we have to train AI to interpret the test.
Of course, you can train the AI as you train a study. And the result maybe is the better in some case.
Yes, but exactly. The student has to be intelligent like me. So it's not obvious.
Guys, our time is quite over, but I would like to thank you again and have your message for our audience, our final message, because we have a lot of students in our audience. So give your message about our talk, about CPET, and advice for the new generation, for the students. The final message.
Together. Do CPET.
Sure. Make CPET great again.
Yeah, it's a good message.
No, but I would say it's like cardiorespiratory. It comes first with cardiorespiratory physiology, and I think you have to love cardiorespiratory physiology, and from that point, CPET comes naturally, and but you still need to learn and to study a little bit, and after that it's like a process going on, and it's really nice because you confront your experience with all of your colleagues, and that is really passionating. So I'd say yes, do it, and don't be afraid. It's like it's a big piece of investment at the beginning, and but I think it's worth, and I would say do it, and the community about exercise physiology is really nice, really helping. They want to improve everybody, and so I would say use it, because as Marco told you, there is many possibility to use it and to say that to diffuse and to exploit it. So that would be my message, I think.
My message is it could seem in the opposite direction of AI, but it's not. So I think that CPET forces us to understand what happens behind the CPET.
Perfect.
So it means it's not a normal test. It's not a value. It's a series of values. So it means that our brain, our intelligence has to put together this information. And I think that AI can help us, but we need to be there and to check what AI does. So my message is do CPET, because CPET is a brain train. CPET is knowledge. Is not just put a patient on bike and make effort. Is looking values, is looking parameter, and try to make a puzzle, and try to give an answer to patients, to athletes, to any people that do CPET. So I think it's very useful to grow up and in a professional career, and also in personal career, because personal experience, because I think that CPET is a really a brain trainer.
Also for the clinical rationale, for example.
It's a cultural investment.
Yeah. Nice. Yeah, it's good. So thank you again for your time. I'm very, very, very happy to have you here. You both here together. So we have a very interesting talk. And for our audience, please follow this video, follow our channel, and share this video with your friends. And thank you for watching the vídeo. And now em português. Obrigado a todos, espero que vocês tenham gostado. E esse foi o nosso podcast. Por favor, compartilhe mande para os seus colegas. E thank you again, Gael e Marco.
Thank you very much.
Thank you.